Thank you very much. Obviously, in the workshops yesterday, we all had a go at this, and so some of this talk will be familiar to you, having participated in that workshop yesterday. So this is the sort of structure of my talk. I'm just going to remind ourselves about how heterogeneous the disease is, a little bit about the science of assessment, the tools that we use, either single or composite domain, and what the future holds. We've seen this slide yesterday, and other speakers have shown similar slides, but it is a heterogeneous disease. Not only does it affect the joints, but it affects the joints in different ways. It affects different sites. You can have dactylitis as well as enthesitis. So to design measures, accurate and reliable measures of assessment, given this heterogeneity, is quite a challenge in this disease. And of course, it doesn't simply apply to the musculoskeletal system, because there are other aspects of the disease. We've just heard about the cardiovascular side, but from our point of view as rheumatologists, we've got the skin to consider, and the skin is heterogeneous in its manifestations as well. And the PASI is essentially measuring plaque psoriasis, but there are other forms that it doesn't reliably measure that we must consider. So we are faced with these challenges in putting together a measure that sort of encompasses all aspects of the disease that we're looking at. I'm just going back a little bit to the science. This is the WHO ICF, International Classification of Functioning, Disability and Health, which is used to structure the way that we look at how disease impacts on the individual. And you can see that it's structured here at the health condition, initially into three sections: bodily functions and structures, activities and participation. And it acknowledges that there are other factors such as personal and environmental that can influence particularly the activities and participation of the patient with the disease. Now, if we map outcome measures that already exist onto this classification, ideally you'd want to cover all aspects of the disease. But if you look at what's already been developed for psoriatic arthritis, you can see it's all on the left-hand side. It's all bodily structures and functions. There's a little bit here in the activities that are generic, and a little bit that cover participation and quality of life. And you'll see I've blanked out here personal and environmental factors because they haven't been covered at all. So I think there's quite a lot of work yet to do in psoriatic arthritis outcome assessment, not only on this side of this equation, as it were, but also here and in the bottom two, environmental and personal factors. Now, we've heard about OMERACT. Rheumatologists will have done, dermatologists perhaps not. But OMERACT's been around for some time. The acronym stands for Outcome Measures for Rheumatoid Arthritis Clinical Trials, and I think the first meeting was in the early 90s or late 80s. And basically this was a group of methodologists and clinicians who came together to refine outcome measures in rheumatoid arthritis to be taken forward in clinical trials so that the assessments were standardized and reliable and could be compared across studies. And it's grown with the years to encompass other diseases. Psoriatic arthritis, as you can see, really came to the fore in 2006 in the OMERACT meeting in Malta. This was led by Daphne. And we ended up with these familiar three circles of outcome measures that we thought were important to measure in psoriatic arthritis. And the inner circle we felt were, as it were, mandatory to use in clinical trials going forward. And this includes peripheral joint activity, the skin, a patient global assessment, patient pain assessment, an assessment of function and quality of life. Out with this inner circle, we had an outer circle where there are areas that were felt to be important, particularly dactylitis and enthesitis, but for which we hadn't actually got a reliable tool at the present time. And beyond that, we have an outer circle, which is really a research agenda, and that included imaging, tissue analysis, and this concept of participation. Now, the OMRAC process is quite rigorous, and each of these outcome measures is examined using what's called the OMRAC filter, which basically has three headings. Truth, does the measure does it measure what it says it's set out to measure? Is it discriminatory? Does it show difference with treatment? Can it tell one group from another? And is it feasible to do? So each of these individual domain measures is examined with the filter. And if we want to put together a composite measure that actually combines all these together, that is also examined with the OMRAC filter. And you'll see how that fits in later on. So as I say, GRAPPA came to the fore in 2006, and we've attended several other OMRAC meetings since. But at the last OMRAC meeting, it became clear that we had one big deficiency in our functioning with OMRAC so far, and that is we didn't have patient participation. And this is a very important part of OMRAC now. And there was no patient input into that previous process. And this slide just reminds me that we are now beginning to work with patients. This is a group of patients and doctors who met under the auspices of EULAR that have put together a new outcome measure called the PSED, Psoriatic Arthritis Impact of Disease. And GRAPPA is going forward with a group called PIOMSA, Patient Involvement in Outcome Measures in Psoriatic Arthritis. And there have been 3 meetings of that group. So we are getting there with the patient involvement. So assessment tools, as I said, can be either single domain, joints, entheses and so on, or composite domains which aim to put these together. The advantage of having a composite measure like the DAS28 is that I can say to you, oh, I had a patient in clinic this morning with a DAS28 score of 6.5. You know immediately what I'm talking about in terms of disease activity. And that combines, as it were, joints and global and the acute phase response. And the idea is to put together a composite measure that combines aspects of psoriatic disease that we can translate into a single figure that makes it more efficient for clinical trials. What about the joints? Well, the only thing I've got to say about the joints is you've got to do a full 68, 66 joint count with our patients. The reason for that is that half our patients have oligoarthritis. So a 28 joint count that we're used to doing with rheumatoid isn't sufficient. You'll miss patients and you'll misclassify them. And this data comes from the Grace study, where we looked at patients with oligoarthritis and looked at 28, 44, 68, 66 joint counts, and found that the 28 joint count misclassified 21% of patients on a tender joint count and 27% of patients on swollen joint counts. And in the UK, in particular, with regard to NICE and TNF drugs, we assess patients at baseline and at 12 weeks in order to assess their ability to continue with the drugs. And if you don't do the full joint count, then you will miss a significant proportion of patients who are responding to TNF drugs. And a recent survey in the UK found that 50% of units were only doing 28 joint counts in their patients. So the thing I would say about psoriatic arthritis and joint counts is you must do the full gamut. Seems a lot, but it isn't. Once you get the hang of it, then it doesn't take that much longer to do a full joint count. What about enthesitis? Well, those of you in my workshop yesterday heard me say that I really take most notice of entheses around the heel, particularly the Achilles insertion and the plantar fascia. But of course, there are hundreds of entheses elsewhere in the body, and there are quite a number of enthesitis indices around. This is the One here I've depicted is the Leeds index, which has got 6 sites, both lateral epicondyles, the medial condyle of the femur, and the Achilles insertion. The Massey's has 13 sites, the Spark has 18. Is there any advantage to doing more sites? I'm not sure there is. We still haven't decided which is the best index to use. My concern is that we don't quite know what, beyond the heel, as far as I'm concerned, we don't quite know what that tenderness means at an enthesis. Lateral epicondylalgia is quite common in the general population. Fibromyalgia is common. There's a fibromyalgia point just distal to the lateral epicondyle. And if you take ultrasound as a gold standard of enthesitis, there's very little relationship between clinical and ultrasound assessment. Furthermore, if you look at the relationship between enthesitis counts and other measures of disease activity, there's also a poor relationship. In fact, there's an inverse relationship between CRP and enthesitis counts, and very poor, these are Spear and Rowe values, correlation between the global scores, the swollen joint count. The highest scores are with the tender joint count. And there's been a study from Milan in Italy that looked at fibromyalgia scores with enthesitis scores and showed a relationship. So what we're measuring when we say we're getting an enthesitis count above the heel, the rest of the body, to me is as yet not clear. And I do believe it is a measure of pain rather than true enthesitis. What about dactylitis? Well, if you see dactylitis like this, it's obvious. And I think it's just as reliable to count the number of dactylitic digits if they're tender. There is this alternative non-tender so-called cold dactylitis. But if they're tender, then I think it's perfectly okay to count the number of digits. The problem arises when there are subtle differences. And this was a patient in one of our reliability studies that over 50% of the rheumatologists missed. Do you spot the dactylitic digit there? Which one is it? Yeah, it's this one, but it's subtle, and this is where the Leeds dactylometer comes into its own, because it allows you to accurately measure the girth of the base of the digit. And we've set a 10% cutoff for swelling in a particular digit. The other advantage of using this is that you can get a numerical figure for your dactylitis. And as you can see here on the left, if you treat people, then you show nice change with effect sizes. However, I think going forward, some people look at me and say to me, well, if you're using one of these, it's going to take you all day, because you've got to measure all the fingers. But that's not the case. You measure the ones that you think are dactylitic. And it doesn't add a lot of extra time. But I think going forward, a simple count of tender dactylitis is going to be the way. And perhaps using this instrument just to confirm the presence or absence of it. What about the spine? Well, one of the problems we face with the spine is there are two different phenotypes with psoriatic arthritis. There's the classical ankylosing spondylitis phenotype, and then there's the psoriatic phenotype, which is a little bit less symmetrical, different morphology of syndesmophytes, more posterior joint involvement. And we don't yet know whether the classical ankylosing spondylitis outcome measures are suitable for this group of patients. So there's ongoing work in this respect to develop, first of all, to validate the AS measures and to develop new ones if possible. And we already have developed a new radiological index called the PASRI, which is taken from a mixture of the MSAS and the BASRI. What about the skin? Well, I think as rheumatologists, obviously it's important to measure it because it's important to patients and it contributes very much to the disability and poor quality of life. But what patients want is a treatment that treats both the skin and the joints. So they're interested in what I can do for their skin as well as what I can do for their joints. And everyone uses the PASI in clinical trials, but every dermatologist I talk to, and particularly Alice Gottlieb, said the PASI is a terrible measure. And it's inaccurate at low levels, and they don't like using it. So what are the alternatives? And there are a number of alternatives that have been developed, but as far as I'm aware are not in routine clinical use. Perhaps the one that is most commonly is the body surface area. And of course you've got the advantage that we don't have, that you can easily biopsy your target organ. Nails are important as well. They're important from the point of view, as we said, as a risk factor, but also in quality of life, in cosmesis. It seems like the modified NAPSI, not the full NAPSI, is being introduced in preference. And if you've only got one or two changes in the fingernails, it's a breeze to do. But if every fingernail has got onycholysis, pitting and crumbling, it can take ages. And it challenges my eyesight, frankly, to count the number of pits in a nail, particularly when there are hundreds of them. So let's move on now to the composite measures. And a bit like with the skin, everyone in clinical trials uses the PASI, but nobody likes it. And everyone in clinical trials for joints uses the ACR responder index, and nobody likes it. And again, it's partly historical, and it's partly the way that it's been mandated going forward by health regulation authorities. Now, the ACR responder index was designed for rheumatoid arthritis. It works best for people with polyarticular disease, and it's unfortunately the standard for psoriatic arthritis clinical trials. It's never been through the OMERACT filter. This is data from one of the first interventional TNF studies in psoriatic arthritis, and you can see that to separate placebo from active drug, the measure works very well. But don't forget, these were people who did have polyarticular rheumatoid-like disease. This is also true for what's called the psoriatic arthritis response criteria, which are basically an ACR criteria with a 30% response. What I showed you in the previous slide was a 20% response. And you can see that, again, there's a good separation between placebo and active drug. So you might say to me, well, we've got this, and in fact the DAS28 does the same. Why don't we just continue using those measures? Well, you'll see going forward why we don't like doing that. I'll just skip that one. And the reason we don't like doing it is because they don't work as well for patients that we see, either in trials or in clinics, who've only got a few joints involved, or have got predominant skin problems or predominant enthesial problems, because none of those measures will take those domains into account. And of course, we all have patients who've got just a little bit of disease, but have got a high impact. This was a patient who only had a big toe involvement, the so-called Bauer digit. But it made a significant impact on his quality of life because he couldn't walk. Here's a patient who's got ankylosing spondylitis and very bad skin. He was a teacher, and the pupils knew where he'd been in the school because there was always a little pile of skin where he'd been stood. He was shedding skin from his psoriasis. This is a runner who had an Achilles tendon insertion problem, couldn't run anymore. And here's just one single knee that made a significant impact. So all these are important considerations for us and for our patients that measures like the ACR20 or the DAS28 really can't accommodate. So we've been looking at developing our new measures, and we've got disease activity measures and responder measures. I'm just going to say a little bit about the responder measures. Daphna's group did an analysis of 3 interventional trials with TNF drugs to develop a new responder index called the Psoriatic Arthritis Joint Activity Index, which is basically a 30% responder index, rather like the PSARC. And the GRAPPA group worked together to develop minimal disease activity criteria. And these are the minimal disease activity criteria. So you have 7 areas to look at, and you have to achieve that low level in 5 out of the 7 to be classified as in minimal disease activity. And they're fairly strict. They're not quite remission, but they're fairly low, so just 1 tender and swollen joint, a PASI of 1 or a surface area of 3%, pain of less than 15 out of 100, global of 20 out of 100, a HAC score of 0.5 or less, and just 1 enthesial point. So they are quite low disease activity. And we've done validation work that's shown that if you achieve minimal disease activity, you get less radiological progression going forward. And this is from the IMPACT study, where we did retrospective analysis of those in minimal disease activity. And you can see that those in minimal disease activity, the yellow bars, had less progression over a 1 and 2 year period. And at the back of the room there, I see, well, there was yesterday, there was the results of the TICOPA trial, the first treat-to-target study, using MDA as a target, showing better outcomes at 48 weeks. So I think MDA is going to be something you'll see coming out in clinical trials and a target to achieve. You'll also see these other new composite measures, the CPDI, the GRACE index, and the PASDAS. The CPDI covers 5 major domains: arthritis, skin, entheses, dactylitis, and spinal disease. And this was put together from the original GRAPPA 5 domains and by Oliver Fitzgerald. And patients were classified as mild, moderate, or severe on really empirical grounds. These cut-offs that he suggested were not data-driven, but were empirically driven, for which he's received a lot of criticism. But it's quite easy to do. If you've done your assessments, you can, in the clinic, calculate the score for the CPDI, which is a big advantage, I think. It's something you can't do with the DAS28, for instance, because you've still got to wait for your acute phase response. This is why the CDI and SDI were developed for rheumatoid, because you didn't have to have your acute phase response. So the CPDI has got some advantages. The PASDAS looks at joints, VAS scores, enthesitis, dactylitis, CRP, and quality of life. Now, the advantage of the PASDAS, like the DAS, is that it's a score from 0 to 10. It's a normally distributed score, as you can see here, so it allows us to set cut-offs for low, moderate, and high disease activity, and it allows us to calculate response. And this is all very important in clinical trials going forward. So these are the PAS-DAS response criteria, and you'll have seen these with the DAS for rheumatoid, that you have 3 areas, a good, a moderate, and a poor response, depending on how much improvement of the score there's been and what the final score is. And we've already gone forward and applied these to interventional trial data. And this is from the Go Reveal trial of golimumab in psoriatic arthritis. So there were 2 active treatment groups, a 50 milligram and a 100 milligram group, and a placebo group. And these are the composition in terms of disease activity measured by the PASDAS at week 14 at the end of the placebo-controlled phase of that study. And the red bars are those people in very high disease activity by the cut-offs that were defined, and the blue, those who are in inactive disease. And you can see that the placebo group, the majority of patients, were in high or very high disease activity still at 14 weeks. Whereas in the 2 treatment groups, there were some in high and very high, but there were a lot more in inactive and moderate disease activity. So this is a process of validation of these new disease activity indices. And in the same study, if you look at the radiological progression at 24 weeks, according to whether their patients had a good, a moderate, or a poor response to therapy, you'll see, it doesn't look very convincing on this particular graph, I agree, but the statistics are quite clear that there is more radiological progression. It's a minus figure here because of the way it's been calculated in those who had a poor response to treatment than those who had a good response, and a significant change as well. So again, this is all part of the validation of these new indices. So if we look at the OMERACT filter, which we talked about right at the start, together with these new composites, and look at truth and discrimination, then we've shown that for each of these new indices. The problem comes when we look at feasibility. As I said, it's possible to do the CPDI in clinic, but it's much harder to do it with the PASDAS and the GRACE. And the reason for this is in the next slide. This is the PASDAS, which I haven't shown the formula up till now, but those of you familiar with the DAS28 will realize it's not easy, but although there are calculators you can get. This is the PASDAS, which is about twice the length of the DAS. Okay, it looks horrific, but if you've got a calculator, it's a press of a button once you put your domains in. But this isn't going to be something you do on every patient in clinic who comes to see you. And we're working towards shorter versions of it. And this is how and why we're doing it. If you look at the cumulative variance of each of the domains in the PASDAS, you'll see, and I've graphed them here by their importance, that the majority of the variance is provided by the patient and physician global scores and the SF36. Now, if you just took those three and did them in clinic, it would take a matter. Well, the patient would fill in the questionnaire before seeing you. The global scores, once you've seen and assessed the patient, take very little time to do. And you might imagine that going forward we're going to have two composite indices, one for clinical trials and one for clinical practice. So the simplified versions for clinical practice should be a shorter version and preferably patient-reported based using that regression analysis. It's similar to what has happened with the RAPID score in rheumatoid arthritis. And we've already done this analysis, you might imagine, and really the shorter versions don't perform as well as the main versions, but you know, they look at this right-hand column, they're all very significant still. So I think shorter versions going forward is going to be certainly feasible and would tick that last column in the OMERACT filter. So as you can see, going forward, assessing psoriatic disease activity is quite complex and it's evolving. We've got to move away, if we can, from using rheumatoid arthritis tools, because although historically they've been shown to work, they've worked in a group of patients who were like rheumatoid-like in their number of joints and so on. So we have to think about covering the wider spectrum of psoriatic disease. And going forward, we'll get new measures, we'll get shorter measures, we'll have targets to which we can treat, and treat to target is a concept, as you can see from the back of the room, that has been supported by AbbVie and that we should be doing going forward into the future. So thank you for your attention.